Good evening, I'm Mike Knetter, and welcome to the UW Now Livestream series, where we bring you experts from the UW community talking about various aspects of the COVID-19 crisis. As a global leader in research, UW-Madison has become an integral part of the fight against COVID-19. With experts doing research in clinical and social settings both, UW is helping advance the way we treat COVID-19 and also how we assess whether the volumes of information we're getting are helping or hurting the cause. Today also kicks off the 10th anniversary of the Wisconsin Science Festival, which is why we moved our program from its normal Tuesday slot. We're excited to bring you two UW experts who will be talking about COVID-19 research and the infodemic. William Hartman will talk about COVID-19 clinical trials taking place at UW-Madison. And Dietram Scheufele will tell us about how communication about COVID is so difficult and what might be done to improve it. Each of them will give opening remarks, and you should feel free to use the chat feature in YouTube to pose questions that we can discuss once they're done speaking. Our first guest tonight is Bill Hartman, a physician, assistant professor of anesthesiology at the School of Medicine and Public Health, and the medical director of the UW Health Pre-Anesthesia Assessment Clinic. He's also the principal investigator for UW's COVID-19 Convalescent Plasma program. His current research focuses on quick implementation of therapy trials to quickly and safely bring novel treatments from the laboratory to the patient. He's working on 3 ongoing trials with the Regeneron COVID-19 monoclonal antibody cocktail to be used in infected patients as well as non-infected household contacts as a method to prevent the development of the disease. Bill, thanks for all you're doing in the COVID-19 fight, and thanks for taking time to talk to our alumni this evening. The floor is yours.
Thank you. Thank you very much for that introduction. I would like to begin with where many of these talks often end, and that's with thank yous. First and foremost, I always have to thank my family, who've accepted the risk of a father and a husband that goes to the hospital every day specifically to treat patients who are sick with COVID-19. They know that they're at risk of me bringing that virus home, but thankfully, to date, that has not happened, and we've just learned to live with that as our reality. I also want to thank my Department of Anesthesiology for giving me the time and the support needed to fight this fight. I'd also have to give kudos to the university for embracing our mission to lead the effort in developing and studying therapeutics and preventative measures for COVID-19. The response of the university has been truly amazing. To the people of Wisconsin and Dane County in particular, who've accepted the challenge to be part of the solution, and they've tirelessly volunteered to be part of these efforts, thank you to all of you. But most importantly, I have to thank the UW Office of Clinical Trials. They're absolutely the best in the business. They've helped me, a molecular biologist and an anesthesiologist with no clinical trials experience, and who had only been at University of Wisconsin for 8 months, but they've helped me more than anyone will ever know. When this fire started in February and in March, they ran right into it, vowing not to rest until the fire had stopped. And they've stood by that. And I can't say it enough, the UW Office of Clinical Trials is absolutely the best in the business. Next slide. I'm going to begin with the talk on the clinical trials that I've been involved with, specifically the convalescent plasma trial, the monoclonal antibody trial that we have ongoing, and our vaccine trial, which we've also brought to University of Wisconsin. Next slide. We'll begin with the convalescent plasma story, as I feel that that's sort of my baby here. Convalescent plasma came to UW via a fateful phone call with my good friend and mentor from my Mayo Clinic days, Dr. Michael Joyner. He had just joined forces with Dr. Casa Duvall of Johns Hopkins, and conceived a plan to develop a grassroots effort to study the use of convalescent plasma in COVID-19. Our consortium started with about 8 hospitals, then grew to about 40, and then to 100, finally to over 2,700 hospitals worldwide, with almost 15,000 physicians using convalescent plasma and close to 100,000 patients to date. To get things going, we had a concept, but we had no plan and we had no money. But that didn't matter to UW. They said, we're going to build this and we're going to then tell others how to do it. We had 2 weeks to do all this. What could possibly go wrong? In this time period, in collaboration with the Office of Clinical Trials and my close partner, Dr. Joe Connor of the UW Blood Bank, we built this program twice. The first time using the compassionate use FDA EIND procedures, which would allow the patients to be able to get convalescent plasma, but the administrative burden was great, and the patients would have to wait to get their plasma. It was slow and it was clunky, and personally, I didn't like it. But all approvals and all IRBs were in place, the order sets were written, the storage facilities for the convalescent plasma were built, and we were ready to go. Working with Betsy Nugent, we set up the ability to test donors using testing performed by Exact Sciences here in Madison. And working with Jennifer Parnell, we developed an amazing partnership with the American Red Cross so that we could safely collect plasma. That relationship between American Red Cross and University of Wisconsin and the people of Madison led us for the first about month and a half of the pandemic, the national, about 1/3 of the national supply of convalescent plasma was right here in Madison. So it was all in place, but we still thought the process would be too slow. So entered the Mayo Clinic, who had infrastructure in place already to establish an emergency access program, or an EAP. If we were able to seed our protocol to Mayo Clinic, it would allow them to really have the administrative burden of handling all 2,700 hospitals so that the patients could get the convalescent plasma much more quickly without having to go through the EIND approval system. So this was advantageous. It changed the way that we were able to get plasma to patients, but it allowed us to be able to treat patients almost instantaneously when we recognized that they had COVID-19. At a time when having COVID and being on a ventilator meant upwards of an 80% death rate, the first five of the first 6 patients that we transfused, who were among the first few people transfused in the country, 5 of these first 6 came off the ventilators and were eventually discharged home. And we felt we were really onto something. After that, we did not really have a surge of patients here at University of Wisconsin. We saw patients trickle in 1 or 2 at a time, but they never came in waves like they did in New York and San Francisco. And this allowed us to transfuse the patients that did come in very early, before they went to the ICU. And we saw that in the patients that we treated with convalescent plasma, we were able 95% of the time to keep these patients out of the ICU and off of ventilators, which opened up ICU beds and allowed us to again open up the hospital to normal operations. So we announced these results to the consortium, and people listened and started trying to do the same thing. Next slide. Here is a note that I received from Dr. Casadevall, who's led the national effort on convalescent plasma here in the United States and throughout the world. And Dr. Casadevall from Johns Hopkins writes in this quick note just a brief thank you for University of Wisconsin treating patients early, being the first to do so, letting others know about it. And he indicates anyway that he believes that the decrease in mortality that was beginning to happen, that we were beginning to see, was probably due to the different way that we were administering the plasma here at University of Wisconsin to our COVID-19 patients. Next slide. As we figured out how convalescent plasma was being effective, new generations of therapeutics were becoming available. And one of the companies developing these approached us in early June to see if we could help evaluate their new antibody cocktail. And so we set up 3 arms of their trial here: an inpatient arm, an outpatient arm, and then a preventative arm for people who are close contacts with those that had COVID-19 but hadn't developed COVID-19 themselves. So we were the first in a group of institutions to set up these trials, and these are currently all ongoing. The Regeneron cocktail, which is 2 monoclonal antibodies, or the two antibodies that attack this virus specifically, that spike protein that's on the surface of that virus, it prevents then the virus from being able to enter the cells, and the virus is neutralized and eventually dies. This has gotten a lot of press lately because this Regeneron cocktail that we've been studying since about June was used to treat President Trump just a couple of weeks ago. He has since called it a cure, although Regeneron did come out the next day and say and remind people that currently there is no cure for COVID-19. Next slide. And this takes us into the final clinical trial that I'll talk about tonight. This is one that we started about a month ago, 6 weeks ago now. Still, for preventative measures, wearing a mask, washing hands, social distancing, and being outside more than inside, those are all the things that you want to do. But to get us living back to as close to a normal life as we can, we do need a vaccine. And so UW was the second site in the nation here to be set up to begin phase 3 vaccine trials in partnership with AstraZeneca and Oxford University and the Oxford Vaccine Group. We had a strong emphasis on minority involvement here in Madison. The COVID-19 virus disproportionately affects people of color, and so we wanted to get real meaningful results, and so we've made efforts to improve our standing and our trust with the communities of color so that they could join in on this trial so we could get a vaccine that would be good for everybody. The goal of the vaccine is to reduce the COVID-19 infections by about 50%, and the disease burden on those that still get infected, we hope, is less. This trial is currently on pause. There was a neurologic event that happened to a patient in England, and they're investigating whether or not the vaccine contributed to that neurologic event. In doing so, the FDA has asked for the information, the safety information, on all 18,000 people that have received this vaccine to date. And so hopefully we will hear within the next day or two whether or not that pause is lifted. We expect it to be lifted, and so that we can begin the trial once again. So finally, next slide, I just want to thank again the University of Wisconsin-Madison for all their support, the School of Medicine and Public Health, which has been absolutely tremendous in this fight, and to all the folks at UW Health that walk into that hospital every day knowing what they're up against. They still come with smiles on their faces and ready to do their job. Thank you.
Well, thank you, Bill, and thanks for sharing this really interesting information about all 3 of these different trials, and thanks for your hard work on the trials, and by extension, a thank you to everyone you thanked, most notably your own family. So really appreciate what you're doing. Our next speaker tonight is Dietram Scheufele, a double badger who holds the Taylor-Bascom Chair in science communication. Dietram is also a Vilas Distinguished Achievement Professor and Director of Academic Programs in the Department of Life Sciences Communication. As a social scientist, his research examines the formation of public attitudes and policy dynamics surrounding emerging science issues. He's one of the most widely cited experts in the fields of political communication, science communication, and science and technology policy. His publications include work on framing theory, participatory democracy, and the science of science communication. He's won numerous national and international awards for his research and publications, but also, importantly to us, teaching awards here at UW-Madison, as well as at Cornell University. Dietram, thanks for being with us. I'm a hard guy to teach, but it sounds like you're up to the job. So take it away.
Thank you, Mike, and thank you for having me. And Bill has set me up almost perfectly because he already alluded to some of the complexities that come with communicating, or have come with communicating COVID and the surrounding policies and things that have affected our daily life. I do want to start, and I've intentionally put here the picture of our campus back in the 19th century when we just started, and how land-grant universities really started, meaning this idea that not only do we do research here at Wisconsin, but as at the time the congressional language called it, we also teach farmers to grow 2 blades of grass instead of 1. So we don't just do the research, we also take this research to the state, and as we heard from Bill, to well beyond the boundaries of the state. But I want to touch on 2 things. The first one really quickly, the question if we are in the middle of an infodemic. The World Health Organization has spoken to this quite powerfully, or has created a powerful term at least. But I do want to revisit that idea a little bit because, as always in the social world, things are more complicated than they may initially seem. And then number 2, I want to touch on 3 things that have really made our life more difficult in terms of communicating about COVID. And some of those are things that would have been more within our control than we maybe thought. So let me start really quickly with a question: is there an infodemic? And this is work with colleagues here at Wisconsin, but actually a perfect example of how we do work at the university. My collaborators here are my department chair, Dominique Broussard, but also doctoral students in the department and a visiting Fulbright fellow from Germany who was doing this work with us while she was here, and actually was doing work during the pandemic and chose not to go back, but rather to stay here and continue to work on this. So it was really exciting. So as we're thinking about if there really is an infodemic, the first question is, are we in a worse spot now during COVID as far as public misinformation is concerned than we typically are or have been in the past? And I'll get back to the answer in a second, but I just want to point out to you, for example, the conspiracy theories around the Gates Foundation, which has long been engaged in vaccinations abroad and elsewhere and really building up our capacity in the area of vaccination, and people have long attacked them for either Bill Gates adding to his personal wealth by doing that, or even engaging in the more out there conspiracy theories in population control. So not new ideas, but ideas that all kept popping back up as we were first trying to get our heads around this new pandemic. And then the second one is of course the maybe more important question, and that is, as we're worried about misinformation, it of course is a problem in itself, but it's particularly a problem if it translates into adverse behaviors like social distancing or the lack thereof, lack of wearing masks, and higher levels of vaccine hesitancy. And again, the question is an open question. Have we really seen that link between more misinformation, or is maybe some of that behavior driven by other factors? I'll come back to that, but I'll say for now that the answer to those questions is really mixed. Either it's a solid no, and that is especially for the last question. We know from decades of social science research and a lot of the work we do with the national academies, for instance, that putting more information out there does not necessarily lead to more science-consistent behaviors. In fact, there's studies, and this is just one here in the area of vaccinations by Brendan Nyhan at Dartmouth, that have suggested that actually throwing facts and telling people why they're wrong about their behaviors and why they should be vaccinating their children can often backfire, or can in some cases at least backfire, meaning people become even more entrenched in their positions simply because we're telling them all the reasons why they're wrong rather than engaging them on the questions that really matter to them. So that brings us really to kind of three challenges that I want to touch on. And the first one is actually one of the big, paradox is the wrong word here, but it's one of the big dilemmas that we're facing with COVID, and that is that we're trying to counter information that we know to be wrong, misinformation about hydroxychloroquine or whatever else, where we know this is wrong, but we're trying to correct that with science that we're not quite sure will turn out to be right. And that has been a real problem during COVID-19, the mask wearing issue being one of the most prominent ones, where CDC guidelines very early on were a bit mixed. And this is, I put this up here because it's a great cover for Tony Fauci in InStyle magazine. But in this issue of InStyle magazine, he also gave an interview where he explained how this came about and how initially they were really concerned about PPE for first responders, didn't want people to go out and buy up all the masks. And so they were a bit more cautious in their recommendations. And then later on, really went all out and said, look, you got to wear masks. But you've heard from political actors in recent times having this or describing this as flip-flopping. And then tonight, some of you may have seen Chris Christie coming out of the ICU and speaking publicly and saying, look, I should have worn a mask all along. But before we got there, of course, a couple other things happen, and that is also if I'm a citizen and I'm going out and I'm trying to figure out what the science is on mask wearing, I'm seeing in the New York Times very visible back and forth between different scientists arguing over the validity of various studies on mask wearing and the science not being settled. And that, of course, was one of our big challenges in COVID, that we basically did a lot of science in a very short time period under immense public scrutiny. And what normally happens behind closed doors, meaning we go back and forth, we falsify, we move forward by disproving initial theories, this time happened very publicly, and that had immense political implications. This is a tweet by Laura Ingraham, one of the more conservative commentators, as many of you know, where she highlighted very prominent retractions from the Lancet, from the New England Journal of Medicine, so highly regarded medical journals who retracted studies on COVID and said, well, next time they tell you to trust the science and they make policy based on that science, just remember how that turned out the last time around. So we're battling at the same time a potential attack on the value of science while trying to navigate a complicated scientific issue. And the political aspect, of course, brings us straight to the second challenge, and that is that human nature doesn't really help. This is a cover from The Week magazine that highlights something that we all understand, and that is mask wearing has become a political act, or a partisan act in this country, at least to some degree, an act that allows us to signal to others which tribe we belong to by wearing or not wearing a mask. And this is something that in psychology and in communication and in political psychology, we've long known as motivated reasoning. And motivated reasoning basically says that all of us, if we look at the same facts, we know those facts to be true, we weigh more heavily, and that's called confirmation bias, we weigh more heavily those facts that fit what we call in communication and in political science priors, our values, things that are really, really important to us. So we confirm those priors by weighing facts more heavily that fit those priors, and we disconfirm them, or we disconfirm those facts rather, that don't fit those priors. And that leads to biased assimilation, the second bullet point here. What does that mean? That means that I take new scientific facts and assimilate them into my belief system. And let that sink in, right? It should be the exact opposite in a democracy. I should constantly adjust what I believe to be true based on new scientific information. Instead, I do the opposite. I take new facts and I assimilate them into my belief system. And I do that, of course, to defend, to some degree, my tribal identities. And when I say I'm not being coy about this, all of us do this to a degree. But for the scientific, or for scientific questions, of course, that means all of us process the exact same facts in slightly different ways and interpret them in slightly different ways. And you can see how for the issues surrounding COVID, the scientific issues, that's really complicating things, because it basically means the same scientific fact means different things to different people. Let me give you one really striking example from that, and that is numbers. When you ask in surveys, this is a survey back in April that asked Americans if they thought that the official numbers that the government puts out on death rates from COVID are accurate. And of course, we would hope that as all of us look to the federal government, that we trust the information that's coming out of the federal government. But the two numbers that you see circled here, on the one hand, Democrats, 2/3 of Democrats think that those numbers are not accurate, that they're actually not reporting the totality of cases, not underreports. And there's probably some truth to at least some underreporting. But on the flip side, you have 2 in 5, a relative majority of Republicans, who think that those numbers are exaggerated, which means on both ends of the political aisle, we don't trust the numbers that come out of the federal government. And you see really motivated reasoning and on full display here on this graph. So that brings us to the last challenge, and that is that, of course, those of us who are in universities, we would love for science to call the shots on almost everything. But that's not how policy works. Policy is advised by science and hopefully based on the best available science, but it's based on a lot of other things, real world considerations. And for COVID in particular, as we were closing the economy, as we're restricting Americans' lives in other ways that in some cases threaten their livelihoods, you have to say that's the way it's supposed to be. And Tony Fauci actually spoke to this as well early on in the pandemic, where he said, look, I know my job is to advise the government. My job is not to tell them what to do. It's to tell them what the best science should be, or is that they should be basing their decisions on. So how can we make sure that the science doesn't necessarily determine policy, because as I said, that's not how it's supposed to work, but informs that policy? And there's maybe some counterintuitive or unexpected lessons in the social science. One is the idea of language, and this is not meant to be read as a graph. I just put that in there to remind me to mention this to you. This is a study out of Wharton, so the business school at University of Pennsylvania. And what they did is, on the x-axis, you have from left to right people's ideology. On the y-axis, the willingness to purchase an energy-efficient light bulb. And the gray line basically says, what happens if you go from very liberal to very conservative? And you see it's pretty flat, meaning no matter what your partisanship is, you're willing to buy that light bulb until, and this is the green line, I put an environmental label on it. I'm basically now signaling this is good for the environment. This is something that Democrats care about. This is something that Republicans care less about. And all of a sudden, you see the willingness to purchase that light bulb go up on the left, and you see the willingness to purchase that light bulb go down on the right, which means it's a total unintended and unnecessary consequence simply by signaling something tribal. And the environment, in my opinion, shouldn't be that, but it happens to be that. We may be making mistakes in communicating simply by choosing the wrong language. And I want to show you one example, or maybe you want to make the case for one example. Mike, in the introduction, talked about a lot of our work being focused on framing. So how do we describe an issue in a way that it resonates with people's underlying values? And we've talked about COVID and the science of COVID very much as a scientific and a public health problem. But for many Americans, it is that, of course, but it's an economic problem. It's a problem related to their personal freedoms and so on and so forth. And both The Economist and Forbes magazine and others have actually tried to reframe the issue and have said, look, mask wearing, yes, it's a public health issue, but mask wearing is actually something that has real economic value. Any given American not wearing a mask for a day hurts the GDP at around $50. Or all the time we're wasting by not being able to reopen in time because we're not wearing masks enough will cost the economy up to $1 trillion, according to Goldman Sachs. So why is that so important? Because rather than putting an environmental label on a light bulb and having an adverse effect, I'm connecting COVID to something that matters to 330 million Americans, and basically are translating a public health or a scientific issue into something that explains why they should care about it and why it has implications for their daily lives, because beyond the obvious medical impacts that that Bill, of course, has talked about. That brings me to the third one, and that's a really important one. I mentioned earlier the idea that of course we're doing a lot of science that we know will be corrected over time for COVID. We already have. We've gone back and forth on various findings, on aerosols, and a lot of other things. But we haven't communicated that particularly well. In fact, we've argued that there's misinformation and we can counter it with science. Well, that science was the best available science at the time, and we knew that would change. And by not acknowledging that, we've left ourselves open to political attacks. And I think that we're paying for that now. And I just want to mention chemotherapy as a really good example, or cancer treatments. I think most people, certainly in the medical profession, but also in other scientific fields, in Wisconsin, from nanotechnology to whatever else, would all acknowledge that chemotherapy is an imperfect treatment for cancer. It's the best we have right now, but we all know there's going to be better treatment, personalized medicine, gold nanoshells, other types of technologies that we're working on fast and hard, and that it will eventually lead to a much better way of treating cancer. To my point, chemotherapy right now is the best treatment that we have at the moment, but it will, and it should change down the road. So we're making that value proposition all the time. We didn't do it very well for COVID. That's what I meant earlier at the outset when I said some of those wounds are maybe self-inflicted. And the last thing is, and this is maybe a positive spin on some of the more depressing elements that I've talked about here, is the idea that some of the same biases that may lead us to engage in motivated reasoning, or that may lead us to not engage in certain protective behaviors, can also be flipped around. And my colleague Dominique Broussard, our department chair, and I just gave an interview to JAMA where she outlined some of what she calls the science of persuasion, and she teaches a class at Wisconsin in risk communication where she talks about a lot of the psychology of persuasion and how, for example, we can use social norms campaigns to change behaviors. What do I mean by that? A social norms campaign plays on the idea that a lot of the things we don't do because we learn more, because we have better facts, because people around us do them. We know that people buy solar panels, not necessarily because they believe in renewable energy, but because their neighbors have purchased solar panels, and all of a sudden they realize this could be something they could be on their roof as well, put on their roof as well. They don't buy flood insurance necessarily because they live in a floodplain or understand the risks, but they live floodplain. One of the strongest predictors of buying flood insurance is that your neighbor has bought flood insurance. So the exact same mechanisms that basically make us engage in some behaviors simply because the world around us does it apply to mask wearing, which is why modeling this behavior is so extremely important, which is why things like the badge or pledge that the Dean of Students Office implemented are so crucially important. So I recommend that piece to you in JAMA, and I'll leave it at that with a real thanks to all the people that have contributed and all the people that have supported our work here at Wisconsin, including Mike's shop. Thank you so much.
Thank you. Two great speakers tonight. Let's get this Q&A rolling. And, I always get to ask a couple of early questions. So, Dietram, for you, I'd like to know, why isn't mask wearing, I know we have to study everything, we're scientists, but why isn't that kind of common sense in reducing virus transmission? And, why in populous parts of Asia, people wear masks, all the time? I guess some of that may be due to pollution, but I would think we would have studied, mask wearing as it relates to virus transmission pre-COVID. COVID's a particular kind of virus. Any thoughts on that?
Well, I think you're asking two questions. I think you're asking the question, what is the medical science behind mask wearing, and to which degree they protect, or different types of masks protect against different viruses. And I think Bill will probably have some input on that as well. But I think there's clearly different types of viruses that require different levels of protection. But number two, and you mentioned Asia, it's a really good point, because when we look in especially in communication and in other fields of social science, we often make distinctions between different cultural norms and how collectivist or individualist a culture is. In the US, as you can imagine is more on the individualist side of things, and countries like Asia are more on the collectivist side of things, typically at least. And Europe tends to be a little bit more in the middle. And I think we saw an almost perfect mapping on that continuum in terms of how quickly people adopted protective behaviors and behaviors that really required a collective response to a problem. And with an emphasis on individual freedom being much more pronounced in the US than it is, for example, in Taiwan or in countries, Singapore, that have a much better track record at implementing those behavioral norms.
Bill, any thoughts about the mask wearing evidence?
Well, I do think we were too late to really start to promote mask wearing. As a physician that works in an operating room, I wear a mask all the time. We do that so that we don't get our germs into the patient that we're taking care of. It seemed like that would be a good thing when there's a viral pandemic running loose on our country, on our world. And honestly, I think that the science was always there, but to what Dietram was saying, we do live in a somewhat individualistic society where people get to make their own choices. I don't know that those choices are always the best choices, but it's not for me to make it for them. That said, I would wish more people would wear their masks.
Yeah, seems like even if it's wrong, it's kind of a low cost mistake, Right. But anyway, a question for you, Bill. It had to be 2 months ago. I think I had a show that night that it was announced Russia already had a vaccine. How's that going?
If you read their data, it's looking pretty decent. You have to believe their data, which comes with its own issues, obviously. But vaccine development in general has gone pretty well, not just in Russia, but here in the United States and in other countries around the world. The technology has been advanced to where we're making these RNA vaccines now, which really can be designed on a computer and then mass produced. The adenovirus vectors that Johnson & Johnson and AstraZeneca are using, they take a little bit longer to grow, but that technology has been around for 10 plus years. So the studies have already been there. So the development as a whole, I know that people have concerns because everything has moved so quickly, but never before has there been such a collective effort focused on one disease with all of the top minds working toward it and all the money that's been funneled toward it to get us to this point.
And Bill, are Chinese scientists intimately involved? Because I would have expected in China, the ability to mobilize resources is amazing, right? They built that hospital in 6 days or whatever it was at the outset of this. And I would have expected to see China on the forefront of developing effective vaccines as well. And I just haven't heard a lot about that. Anything happening there?
They do have a vaccine that they've been working on as well. I do have to credit the Chinese. Right as the first person, I believe, in the world was dying of COVID-19, they were publishing the genetic sequence of the virus so that the science would be there for scientists everywhere to get out and see if there was something that was attackable. They kind of went against what the government was suggesting that they do at that time. And they put it out there and said, take this and figure out what you can, because we need help too.
Good to know. Well, audience question from Mary Dunphy. What is the difference between monoclonal and polyclonal therapies? Dietram. No, Bill.
Well, the monoclonal therapies that are developed against the COVID virus, they are specific antibodies that attack the spike protein. One of these was taken from convalescent plasma, and one of them was taken from a mouse model that has a human immune system. It sounds a little bit crazy, but that's what it is. And they saw that these two antibodies, that they're able to attack the spike protein in different spots, which allows then, if the virus were to mutate, it's much less likely to mutate against both of those antibodies. But they're clones of each other within the cocktail. If it was a polyclonal, there'd be many different kinds of antibodies all in that mix. Here, there's just the two antibodies and then all of their clones.
Dietram, audience question for you. Is the level of trust in government reporting, does that always break down along party lines where, we distrust government information when the other party controls the executive branch? Is that sort of a common finding these days in our polarized world?
I mean, I think there's always been a little bit of that, right? That there's different attitudes among Democrats and Republicans toward the executive branch, period, not just reporting of data, depending on who is in the White House. I think the interesting thing about the graph that I showed is that, yes, you have a 2/3 of Democrats that don't trust those numbers, but you also have 40%, a relative majority of Republicans who also don't trust those numbers. So it's actually both who, that's the almost a bipartisan endorsement of non-belief is a bit striking. But I'll flip that around and say, and there's a real positive in all of this. We just published an overview of the last 30, 40 years of trust in institutions in the US and public opinion quarterly, and showed that actually there are very few institutions in the country that have increased since the 1960s in their level of public confidence. The military is one, and it's actually the only one that's ahead of science since 9/11 in terms of public trust. And then science is second. And science has increased in its general confidence ever so slightly since the 1960s. And in fact, even a little bit, it's in between 2016 and 2018, which are the last 2 years. And all of that has happened while public trust in almost any other institution, from journalism to business to everything else, has declined. So I think science has done really well, and that's also, I think, why having a nonpartisan footprint for an institution like Wisconsin, a nonpartisan kind of research that contributes to the state is so crucially important, because we do research for everybody, and staying away from the political battles, or the partisan battles, rather, is the right word, is so important. But I think ultimately we're really seen as an honest broker of information, and that's a great thing.
Oh, that's why we love bringing experts like you on this program. I think there's a real hunger for that. Question from audience member Mats Johansson. What is the predicted time frame for general approval and use for Regeneron's cocktail, Bill?
So Regeneron and Eli Lilly, both makers of monoclonal antibody therapeutics, have applied to the FDA for an EUA, or emergency use authorization, which would allow for the medicines to be used in patients who have COVID-19. Neither of these companies has received word as to whether or not they'll get the EUA. I think that our information and our data on the Regeneron is probably a little bit lacking at this point. The only published data or data that's out there is on 275 patients, 1/3 of which have received a placebo. So while the data is very strong and it's very good, it's still only 275 people. And we just have to make sure that it's safe and effective in larger amounts of population. The other side of that too, though, is that once it does become approved through the EUA mechanism, you still have to mass produce it. And currently there's just not enough available that it would make a huge dent in the mortality and the rates that we're seeing with COVID-19. But they do say, or they do feel, that they could manufacture to scale relatively quickly, but it would still be probably the beginning of next year where we see enough doses that we could really be therapeutically useful.
Can I just follow up and ask, how long do these pauses in trials, like we're going through with the AstraZeneca Oxford University vaccine, how long do these pauses typically last? And do we know when that study might restart?
It's variable with the length of time for the pauses. This pause has been frustrating from a person who wants to get this vaccine out to people as quickly as possible. But the other side of that is we have to make sure that it's safe for everybody. And the mechanism in this case worked. One person in England out of 18,000 in the world was found to have an effect that didn't make sense. And everything shut down so that we could investigate whether or not the vaccine contributed to that. The other countries, including England, have gone back to injecting the vaccine and studying it. But the US has the most rigorous standards. And they are making sure that every rock is looked under. They want to make sure that this is the safest thing that can be available to all people. And so I credit them with the integrity and the veracity with which they're investigating this. And we do expect an answer any day now.
Okay. So it's just we have a much higher standard or lower error tolerance for those vaccine trials.
Although I did see a tweet earlier today from a person in England, and he was speaking on behalf of folks in India as well, saying, please don't think that we don't have high standards as well.
Yeah,
but
sure.
The U.S. does tend to have the highest standard in terms of determining safety.
Okay. Question from Dexter Patterson. Dietram, what can scientists do to better close any communication gaps with the public?
Yeah,
You gave some good ideas around that, I think, in how we talk about evidence and characterize it.
No, absolutely, and it is not a new question, right? I think what a lot of people don't realize that most land grants have communication departments in colleges of ag and life sciences. Cornell does, Wisconsin does, because in the mid-19th century we realized that that's actually one of the central problems. How do we bring science to the broader public? And I think there's a couple things that are really important. One is, I think very often we as scientists, we're answering the questions that we think the public should be asking because that's how we think about the problem. But very often those are not the questions that the public is really asking. I think COVID is a good example of that. I think some of the new technologies that many of us at Wisconsin are working on, if that's CRISPR, many of you probably saw the Nobel Prize in Chemistry just going to two pioneers of this new genome editing technology that will also eventually allow us to change the human germline in heritable ways. Of course, that's exciting in terms of, for example, curing debilitating genetically inherited diseases, but it also raises huge questions. If humans make changes that will be passed on to the next generation, to biological children, should we be doing this? Is this natural? How does this correspond with people's religious beliefs and so on and so forth? So I think a large part of closing communication gaps is to actually answer questions that people are asking. And I think sometimes we're giving very good technical answers to all the wrong questions rather than engaging in it. Wisconsin, I think we're better at this than most other places because embryonic stem cell research has been an issue that's really important for us and that really is hugely important scientifically and to find cures for various diseases, but one that came with some of those questions already. So I think we're well ahead of some other universities in having thought through the more complex ways of doing public engagement. The Science Festival that you mentioned is a good example. And all my colleagues in the Department of Life Sciences Communication, including our doctoral students who try to answer this question literally every single day.
Thank you. Question from Danielle, probably a very practical one. Dietram, who can enroll in the trials at UW-Madison, and is the vaccine trial still enrolling people?
You mean that for Bill?
Oh, sorry, yeah, Bill.
I can take that one, yes. So actually, they have just launched a clinical trial search engine here at UW-Madison. And so if you go to clinicaltrials.uwhealth.org, you can put in just a couple pieces of information and search for whatever clinical trial you're interested in. For the COVID clinical trials, we have 4 or 5 that are listed there, and they'll give you the phone numbers and the people to contact so you can learn whether or not that's a good trial for you. In terms of the vaccine trial, we are still enrolling. We have the clinical pause, so there's quite a long wait list at this point, but absolutely, if you're interested, give us a call and we'll see what we can do about getting you signed up.
Great. Question from audience member Ken Dale. What is the best source for up-to-date COVID information? There's a lot of places putting it out, right? And he wonders, in other words, is there a Consumer Reports for the latest in COVID science?
And I'm sure Bill has thoughts on this as well, especially at Wisconsin, but I'll mention a couple things. One is a lot of universities, and Johns Hopkins being an example, Harvard being an example, and again, I think Wisconsin as well, maintain websites that basically put out the latest science and really summarize it nicely around various types of areas of COVID science. The other thing that's maybe less obvious, Twitter gets a really bad rep on a regular basis for misinformation and spreading misinformation, but Twitter is also a place where you can find some of the very best journalists on this topic who've been writing about this. Maren McKenna is a good example. Helen Branswell is a good example at STAT, both of whom have been science writers in residence here at Wisconsin and have actually worked with our students. But these are people who for the last 10 plus years have written on infectious diseases. And it's not just what they're writing themselves, but they also curate and kind of comment on a lot of the other stuff that's floating around. So following them for me is a really useful way of sifting through information that I just don't know as well as they do. So that's for me a really good filter that separates signal from noise.
And I agree with Dietram there. STAT is an excellent resource, daily periodical that gives you really the most up-to-date and current information on, for me, COVID therapeutics and the vaccine sciences. Beyond that, we have incredible resources right here at Madison. The head of infectious diseases, David Andes, Nasia Sadfar, people that you see a lot interviewed on TV, but they're tremendous resources. They've got this community at the core of who they are, and they want to get the best information out to people to keep everyone as safe as they can.
Great. Question for Jacqueline Hartman, from Jacqueline Hartman. Can anyone of you give us some specific strategies to use to help loved ones stay safe, wear masks, and avoid gatherings, besides what I do, which is lead a hermetic existence? Any thoughts about that?
You know, the stories are out there. The ad campaigns are doing their best to really hit home the need to wear masks. I've got 5 kids, but my 3 youngest kids go to a local private school, and they're back in school. And these kids from kindergarten through 8th grade have all learned how to wear their masks all day long, and they do it without any problem. They're not so great at social distancing yet, but most of them don't know what 6 feet really is. So I'll give them a break on that one. But for the most part, if these kids can do it, I believe anybody can do it.
And I think a large part of it, I mean, to just build on what Bill said, I think a large part will be to model the behavior, even though other people may not be doing it. And it's a really imperfect parallel or comparison. But fashion sometimes takes a little while for people to follow the latest trend. We see some people do it, and we don't do it that season, but the next season everybody does it, and it's not dissimilar from this. So I think the most important thing is to not give up on modeling the right behavior, even though other people may not be doing it. It's not that makes it be completely useless. In fact, that may in the long term establish really the social norm that we need.
Question from Laura Heisler. Bill, are you concerned that a vaccine may not work in view of the fact that some people appear to be able to get reinfected?
And so I think that that's a very good question. We don't know how long the immunity in a person lasts. We definitely don't know how long that immunity lasts in a person who's been vaccinated. The vaccines now, all except for the Johnson & Johnson one, have gone to 2 injection vaccines. So they think that you need a booster dose to help boost your immunity to that point. That said, the spike protein on the outside of the virus tends to be very well conserved and doesn't mutate that often, as far as we can tell. And so the majority of the vaccines are targeted towards that spike protein. And so I think that a vaccine would still be quite effective in the vast majority of people.
What is the likelihood that we've skipped over potential simple, easy over-the-counter medications that could help with the virus? Matthew Bangert wonders, zinc, vitamin D, things like that. Anything we know about maybe reducing its severity even?
Well, Matthew, I think that's a great question. I take zinc every day. I think that it is something that it's inexpensive and likely useful. There's not science to state that yet, but many have speculated that it is a good mineral to be taking. Vitamin D, vitamin C, we give to our patients in the hospital. So it's still part of the treatment that we're giving patients. So I don't think that we've skipped over these things at all. I think that they're less sexy to talk about. So perhaps the information isn't out there like it should be, but we're definitely using them.
What about ginseng?
I have not used ginseng, so I don't know the effectiveness of that yet.
I was gifted a bottle of ginseng-infused whiskey. That's why I asked. Sorry. Jamie Anderson wonders, what have we learned about reading and watching the news?
From COVID? Interesting question. I mean, I think we live in a very, very unusual information ecology. We live in an environment where most of the profits in news comes from tailoring news toward what we already believe. That started with cable, and in a social media environment, that's where the money is. That's where the money for Facebook is. That's where the money for Twitter is. It's curating content that tells me what I already know and believe, and that obviously doesn't help in terms of us exchanging ideas across lines of difference. I think COVID has proven this to the nth degree, and I think we'll do a lot of soul searching certainly after the election, regardless of the outcome, on how to create a better environment where we have more open discussion that brings out the best available evidence quickly, especially as we're working our way through crises like this.
Great. Well, we're coming up on the top of the hour, and I just would like to thank each of you for taking time to be with us tonight and share your views. It's been really a pleasure to hear your insights on this. I'd give you each the chance to offer any closing thoughts or words of optimism if you can find them for our audience. Dietram?
I mean, during a time like this, having an institution like UW around, with certainly the medical institutions that Bill was talking about, but also the kinds of interdisciplinary research that really tackles COVID from all directions. From my perspective, there's no other place to do this kind of work, and I'm glad this university exists, and I'm here.
And I echo that. It felt like we were building the parachute after we jumped out of the plane initially, but I feel like we're going in for a soft landing now. These people that I work with every day, they work tirelessly to find the cures, to find the therapies that are effective with patients with COVID-19. And I truly feel hopeful that we're figuring out the best ways to get our people healthy again.
Great. Well, thank you both for being with us. It's been a pleasure to have you on the show, and I look forward to seeing you around campus soon enough, let's hope.
Thank you.
Thank you so much.
So we're very happy here to be a part of this year's Wisconsin Science Festival with this program kind of helping kick things off. You'll be able to find more than 100 virtual and free events for people of all ages. The UW Now will be back again next Tuesday, October 20th, and I'll have special guests, Chris McIntosh, Barry Alvarez's right-hand man in the athletic department, and Matt LePay, the voice of the Badgers. And with any luck, I'm stalking Jim Rome, who is a UW parent and has a nationally syndicated sports radio show. So that should be an outstanding segment next week. I hope you can join us. We will, of course, be doing that to sort of kick off homecoming week and the first Badger football game of the season. Thanks for joining us tonight. Be well, and on Wisconsin.